Well, welcome. When Ian suggested we do this on a fall evening, on a beautiful fall evening, I really didn't think we were going to get this kind of attendance. And it's wonderful that this number of people have actually come. So thank you for coming and welcome. Let's get right into it because we have a lot of slides and a lot of things to talk about. How many of you have seen this? I know that Ted has presented this study before. So when we think about trying to predict the end-of-life phase for the people in our residential care facilities, and I understand tonight from Dr. Bailey that that figure, the average length of stay, is now sitting at about 20 months. And I also understand that there's a small cohort of people, perhaps up to 20%, who actually die within the first 3 months in residential care. You know, so there's a kind of bimodal thing happening here, and probably even further divisions of within that. But our people who are coming into residential care are living for about 20 months on average. So this study looked at 300 odd people for 18 months. The study was in 2009, I think. And they came to some conclusions about these frail elderly people. You will see that they were really very frail. The MMSE was quoted as 5, which you will recognize as being very low indeed. They were scattered across 22 nursing homes. So this is the key slide. Of these people who died, when they looked back, there were 3 things that predicted that they would die within 6 months. And those 3 things are in the center of the slide. An episode of pneumonia was a strong predictor of death within 6 months. Any kind of febrile illness was a strong predictor of death within 6 months, and an eating problem. And you can see that they've kind of parsed out what those eating problems might be for those patients. So I asked Ted when I was trying to prepare this talk, has there been anything fresh since this CASCADE study? And he said, no, there's not really any follow-on from that. So in terms of trying to pinpoint people who are coming into residential care, and in terms of, in our heads, trying to think who is likely not to be with us in 6 months' time, this is as far as we've got in our thinking at this stage. And just to remember, though, that we do have a sense of how people fail, and this shows the relationship between a frailty level drawn from the Dalhousie map with the FAST scale. And you can see that there is a kind of linkage as people change through these different scales. Now, I think Ian wanted us really to focus on the last week or 2 of life and what that looked like, and talk about perhaps palliative care order sets and so on. So I dug this up. It's old, May 2008, and the slide is ugly, but the things haven't changed on this slide. These are the features of patients who are dying within the last week or 2 of their lives. And these are things I'm sure that you recognize. Is there anything on this slide that surprises you or you don't recognize? There's another slide like this coming up with more features. Does anything surprise anyone? Yes? Yeah, I think that happens actually, especially when things like opioids are started, you know, and they do develop kind of altered sensation. This is the other list. As I said, don't try to write all this down. It's going to be available to you, okay? Anything on this slide surprise you? Nope. So one of the things that I wanted to suggest to you is that faced with lists like this is not how you're going to speak to family members. You know, you're not going to offer them 2 pages of lists like this. And what I find myself doing in real practice is I find that I identify 1 or 2 or 3 things that the family member might actually track, if you like, as the final days are happening. So that, you know, there's not going to be a surprise if the person stops eating. When do we usually start talking to the family when the person stops eating? When do we usually start? We usually start when they stop eating, you know, and the family member says, they're not eating anymore, you know, big surprise, you know, really. But I think in advance, it actually does help to prepare people, to prepare loved ones, that this is going to happen. Decrease in urine output, if there's a catheter there, you know, sometimes the urine does go like tea. And I think if you prepare the family in advance for that, it takes some of the trauma out of it when it actually happens for them. And then you all know about mottling, which happens very close to the end. You know, the kind of mottling and purplish appearance of the extremities and the knees and things like that. So these are things that I think you would be talking to with family members in advance, because you've walked this way many times before with your patients and you recognize it and you see it. The family members may not even have seen death before, and they certainly haven't walked this way as often as you have. So I think that's an important thing to do. Okay. So I'm going to start talking about the surprise question, but I wanted to put this up. Do you all recognize what this is? Where do you find this? Somebody said it. When you're registering someone with the Palliative Benefits Program now. Now, we used to have the PPS for this, but we actually found that it wasn't really working very well in terms of predicting people who were going to need a palliative approach. And this is the SPICT tool developed in Scotland, and it was co-opted really for our palliative benefits program because we felt it was more useful. Now, why am I talking about the surprise question with this? Because initially, the surprise question was embedded in the SPICT tool. But you may have heard that there's some controversy now about the use of the surprise question. Who knows? Who can tell me what the surprise question is? Would you be surprised if somebody was dead within the next 6 months? That's right. So one of the problems is that many of us think that it might be possible for somebody to be dead within the next 6 months, but not all of us are willing to hang our hats on the fact that it's probable that people might be dead within the next 6 months. So there is a difficulty with that question, and that actually has been a bit more obvious in recent months and in recent literature. This is the tool that the renal people use for end of life. I'm just showing you some tools at this point. And lo and behold, they've got the surprise question in this one. Okay? So people do feel it might have some use. And I think it might have some use too. But a warning, a meta-analysis recently showed that it's only of mild to moderate use. Okay? It's not a very good tool. It's of mild to moderate use. And yet another tool that people use, this again is out of Dalhousie, and it combines a comprehensive geriatric assessment with, and if you'll see right over on the right-hand side, with the frailty scale. So this is an attempt to really kind of capture a person's status on admission to a program or to residential care. And talking again about the surprise question and palliative order sets, I don't know if you know that there was a thing called the Liverpool Care Pathway. Many of you have heard of that phrase. So this was, if you like, a palliative order set in the United Kingdom. And it was strongly promoted by the palliative care community, and it really took root. And it was an order set, a kind of process for patients at the end of life. The problem was that this order set was applied in a mechanistic way. And physicians, nurses, were neither trained adequately to administer this order set, nor did they take the time to adequately have the communication, the conversations with families about what was happening to the loved one. So that there was a furor in Britain about patients being put on a kind of palliative course with no real discussion, and that was the problem. So the Liverpool pathway was actually pooled in Britain, and needless to say, everybody else has started developing new palliative order sets in a much smaller, homelier way, but that's what happened there. And this is part, even as recent as last month, this is part of an ongoing discussion in the United Kingdom about diagnosing end of life and starting end of life treatment. So this is where they're coming from. It's true we're not good at predicting death. We're not. Nurses are actually better at it than physicians are. And we can't foretell the future, but it's actually much more likely that we're going to run into trouble if we don't recognize people who are getting into problems. Now, some of you will recognize this. This was brought out in June of last year, June 2016, and then it was modified, I think, at the end of October last year. And this was the college's attempt to manage the opioid crisis by restricting opioid prescribing by physicians in chronic pain. Now, this has had some unfortunate side effects. Some 4 weeks ago, we got involved with a lady in residential care at the request of the GP. In fact, the GP had managed this lady beautifully. She'd fallen, she'd fractured L4, and the GP had titrated her fentanyl to a point where she was comfortable. And then along came the guidelines, and the GP got a little bit concerned about the appropriateness of what he was doing. Pulled down the fentanyl, gave her breakthrough Dilaudid to manage it, and the old lady's condition literally fell apart. He asked us to come in and help, and we basically retraced his steps and put her back on fentanyl. She's now beautifully controlled. I saw her myself last week. She's happy, she's smiling, she's walking, and quite different state of mind. So unintended consequences from the college. I think one of my colleagues is going to go over this slide again. This is the pain ad scale for non-verbal patients. This lady had a pain ad of about 10 when we went to see her. And last week I would have said that she was 1 or 2. Her score was 1 or 2. So there we go. And just if you need to waive justification at the college for something that you're doing in residential care, this is the study for you. This one came out, I think, 2011, and it was a stepped approach, and it's not showing up. Okay, so the stepped analgesia that was used was Tylenol to begin with, a little bit of morphine, or a little bit of the Butrans patch, which is covered in the United Kingdom and Norway, where this was done, or gabapentin. So these were the three-stepped drugs that they used. And that was compared with usual care. This was the outcome. The study ran for 8 weeks. The trial patients are in red. You can see that their behaviors improved. The scale dropped. The trial ran for 8 weeks. At 8 weeks, it was stopped. Look what happened. Their behaviors came back again. Okay? So, you know, I think that it's an important thing for you to know that there is evidence that managing chronic pain in residential care facilities makes a difference to people's behaviors. I'm going to be very short on time, so I'm going to run very quickly. This is a very recent study, 2017. In the last week of life, these are the symptoms that are represented in residential care. This study came out of the Netherlands. The people who wrote the study claim that there is no other study like this that actually portrays the symptoms of patients at the last week of life. And you'll see that pain and agitation, pain and shortness of breath, and pain alone, and then shortness of breath and agitation. These are the relative numbers, relative percentages of patients there. And then breaking it down into the kinds of death that these people died. So just kind of dwindling away, dehydration and cachexia, like your very advanced dementia patients. This is what they suffer from: cardiovascular diseases, end-stage heart disease, and then respiratory infections you would expect to be very breathless. This is another fascinating study from last year from Calgary, where they divided care homes into two different groups. And they have a thing called a context frame for residential care facilities, and they choose 10 variables by which they grade the residential care facilities. So things like leadership, staffing, staff turnover, space, electronic records, things like that. And you will see that the low context facilities, actually this one's confusing, this behavior one, because it seemed that the high context facilities had higher representation of severe dementia anyway. It was as if people had selected to send their worst patients to the high context facilities. But apart from that, everything gets worse towards the end of life, and the low context facilities seem to do worse towards the end of life. This is my last slide. If you need us, this is what you do. You fill out one of these. At the moment, we only have dedicated time on a Thursday morning to do residential care facilities. But if you need us, that's what you do. You fill one of those out and fax it to us. Do we have time for questions or not really?
Brilliant.
There'll be time later.
So my thanks to Dr. McGregor for providing these cases. And as some of you may have known for being involved in educational events, I'd like to get people to roll up their sleeves and do a little bit of work. So I'd like you to look at the person next to you, perhaps in groups of 3, and we're going to go over some cases, and we're going to talk about them for a few minutes. I'm going to be finishing my part by about 1:45, so we don't have a whole bunch of time. So this is Brenda. She has advanced dementia. She is a retired piano teacher. She's had progressive functional decline for over 18 months, and she's been at the facility for that time. 6 months previously, she did end up going through emergency to the hospital, and she was treated symptomatically with a blood transfusion, as well as PPI, but nothing further was done, no major investigation. She was sent back to the facility. She's got some mild contractures of her lower limbs. She has a sacral ulcer, which can be painful during dressing changes. She's severely frail. She's dependent on others for all of her personal care. She will feed herself, but inconsistently, often needs significant assistance, and she will choke on her food occasionally. She's incontinent of bladder and bowels, and she's up in the chair, but only if needed. She's known to love animals and jazz standards, Ella Fitzgerald. So, she was identified by the staff as potentially benefiting from the palliative care. She did have, if you think about the SPICT tool, she did have some general indicators with deteriorating performance status, significant irreversible weight loss. She had some disease-specific factors as well, of frailty. She's eating and drinking less, and of course dementia is a major driver of frailty. She's unable to dress herself, and she has, as noted, some smaller difficulties. So, it's great to identify patients, to think about them, to begin to shift the culture of how we're caring for these patients, and yet there must be a so what. There must be a palliative approach plan in place. This is but one example of what a palliative approach might look like for this patient, and it will vary depending on the context of facilities. But in this hypothetical facility, the palliative approach was instituted and involved a palliative care conference with the family. So a palliative care focused conversation where the family was asked, what do you understand? What is meaningful for your mom? What are you hopeful for her? How can we make this last part of her life the best we possibly can? And then the goals of care, including the most, but not in any way limited to the most, is made. Pain and other symptoms become more routinely assessed and managed. Regular Tylenol in this case was instituted. A VHA document called the ACP tracking record, you guys can download that anywhere and put it in the front of the chart. The whole care team can put their conversations, the results of their conversations, on this piece of paper so that when a new staff member comes in, they can open it up, look at the green sleeves, and they can see what kind of conversations have been happening with that patient and family. And that's reviewed in this hypothetical context every week by the CNS, but every facility will be a bit different. Medication is rationalized, so that's more than reconcile. It's really looking at the goals, as Ted Rosenberg has done so beautifully over and over again, and the polypharmacy folks have talked about, where you look at what is the goal of care, or what is this medication, what is the goal of, which goal for this patient is this medication reaching? And is it reasonable to continue it, decrease it, discontinue it? Deprescription. Staff are also informed of the shifting goals of care through a palliative care specific plan and also in staff habits. And animal visits are arranged. I'm rapidly running out of my time, but I wanted to share with you a story. I went on holidays to visit my sister in Sri Lanka this summer, which was an amazing country. And that place, what's really interesting about that culture is how spirituality is very woven into their day-to-day life. And I remember my father is a, what would you call him? He's a wastewater engineer. He designs sewage treatment plants. And we used to joke that Dad, on any family holiday we would go on, we would end up visiting a sewage treatment plant. Always. So what did I do? When I was halfway across the country, I went to go visit a hospice, and I went to go visit an aged care home. Jim off the old block, I guess. But what I found there was that they really made attention also, not just to the physical, but also to the spiritual. They had shrines there for people who were of Buddhist faith, people who were of Hindu faith, people who were of Christian faith, and people who were of Islamic faith. And those people were taken to those shrines every day. I kind of think whether they wanted to or not, they were taken. I'm not sure what the answer is in our culture, but I worry sometimes that that spiritual piece, that is a good part of, wonderful part of our holistic care, is lost. And I just challenge you, when you think about your patients, think about not just their physical, not just their emotional or their social, but also that spiritual. That's my little piece on a good palliative approach. So what I'd like you to do, when you're thinking about anticipating, communicating, preparing the patient, family, staff, and ourselves for this patient's change, to come together. So what's happened to Brenda now is that she really likes Kentucky Fried Chicken coleslaw, which she was given 4 days ago by a family member, and she choked, possibly aspirated. Now she has a declining level of consciousness, some trouble swallowing, coffee ground emesis. She has a history, remember, of the GI bleed previously. So anticipate what symptoms are likely. Communicate. What are you going to tell the family? And prepare. How are you going to support this stuff? So I'm going to ask you to turn to your dyad or your triad and talk about that for a few minutes so that then as we move forward, you will have context for what we're going to discuss. Okay, so here's John. John is 59. He's been in residential care since his MBA 18 months earlier. He had some cognitive damage, a left hemiparesis, very basic verbal responses, but can communicate. He's developed some painless jaundice and was found to have a pancreatic mass, liver metastatic disease at the time of diagnosis, and he did have a biopsy, and a biliary stent was put in. Great palliative care, excellent palliative care. His wife had an MI and is unable to care for him at home, but visits regularly, and is his health care representative. 2 grown kids. When the biopsy results came back, his wife felt he would not have chosen chemotherapy, and so he did not end up going to the cancer clinic. Also good palliative care. So he was identified with general indicators from the SPICT, declining intake, weight loss, and that there was a request for supportive care, and disease-specific measures of declining performance status and too frail for treatment. In this context, in this hypothetical facility, there was a family teleconference. Most was completed. He's now an M1. Medications were rationalized. Goals of care were documented, more than just the most. Pain management is a primary goal. Peaceful death at the facility. He would rather be sleepy than have pain, on balance. That's not that way for everybody. Staff were informed at monthly supportive care rounds that are in this hypothetical facility. But this is what we've instituted at a couple of our facilities here in town, and they've been going, I think, very well. Teresa? And someone from Selkirk, you've been having monthly palliative care rounds, and I've enjoyed them, and I hope that they've helped bring a palliative approach to your facility. And in this hypothetical situation, they've decided to mark that patient with a sticker on the MAR because that's where many people will see, that's how they will connect with the patient's chart. But it honors what this facility was concerned about, which was confidentiality. So in this case, he has a PPS of 30%, clinical frailty scale of 9, which is terminally ill. Pain is stable for now, which is that my son's in grade 8, bit of foreshadowing. On hydromorphone, 8 milligrams POBID with only occasional need for breakthroughs. So for him, what will you anticipate? What crisis will you prepare for? How will you communicate with the family? And how will you prepare the staff to best care for this patient? How is the care going to look different? And really, how is it the same? And I'm going to ask you to come together again and spend just a couple of minutes talking about those 3 things. Okay, I just want to spend a couple of minutes asking for some volunteers to share some of what they discussed. It can be anything. Something that felt really important to share with your partner, or something that surprised you about what your partner said. In my job, I use a lot of silence to make
She's comfortable.
So, how are you guys doing? Go ahead, Dr. Fawn.
Yeah. Did you need 8 milligrams of BID or did you need 9?
Leah said, oh my goodness, someone's going to pick up on that. And that is a detail that I missed when I was filling it in, and my hope is that we'll be looking at the general principles rather than the details of the Thank you for pointing that out. What about symptoms that you would anticipate for these patients? What are you going to have to prepare? I know you guys know this. Let's just get it out there.
You have to prepare the family.
Prepare the family, and there's some ways in which you would prepare the family. Pardon?
Family conference.
Family conference. This is the key to the palliative approach, is the conversation with the family, and then understanding what they understand so that everybody's on the same team. And then once you can figure out what the goals are, everything just seems to, not always, but it seems to be a lot more straightforward.
Should there be MRP involvement in those?
Should there be MRP involvement? And you know what, I'm going to throw that back at the group and ask, what do you guys think? Who should be leading those conversations? Should it be the facility staff, the most responsible physician, the social worker, the spiritual care provider? Pardon?
That depends on the individual family.
Individual. Great. Yeah,
Depending on
great.
the relationship between the physician or the nurse or whoever has the best relationship with that person.
And I think it depends on your context as a practitioner too. It may feel really comfortable for the staff at the facility to know that the person who is leading the medical care is also leading those discussions. That would be my instinct. And so long as that information is shared amongst the team, I would say that's one of the most important features. But I know, as someone who has gone through a number of medical hiccups with my daughter and with myself, it was always extremely reassuring to know that the physician was involved in those important discussions about where we were going with care. Does anybody have any any comments about that?
Issues should be discussed at the admission care conference, including be prescribable and
So we're talking about a palliative approach from the moment of touching the facility. You're my star pupil. I saw another hand, and I'm going to hand it over to Leah.
With what you're saying with who should have the conversation, I find in residential care, you've got some physicians who, they're there every week, they get to know the patients and their families, and then you have some who you see less often. And I really commend the physicians who are there and a part of the team and known to the families, because it is really hard to have the conversations with the families from the nursing perspective when they aren't as familiar with their physician, because they want to feel like the physician is there. And when it feels like the nurse is always the go-between, it can be more of a challenge, whereas if they have a good relationship with the physician, it doesn't feel so much like the nurse is a go-between. It's more of an inclusive team approach where maybe the physician is the one in the conversation who passes it to the nurse or vice versa, but you're a team with that. So I think having physicians there is really helpful.
And I love what you said about team. That there's no one person who's the most important. We all have our roles within the team, definitely, and that the physician is part of that. Yeah. Okay, I'll hand it over to Leah.
So, to pick off from where my colleagues have left us, I think we now want to move into a stage where we're honoring what Ian asked us to do, which was really to talk about the nuts and bolts of some symptom management in the final days and weeks of life. And this was just a slide to sort of say, in many ways, regardless of what we're dying from, there's often a common look to those final days and weeks in many ways. And a lot of the things we're talking about can apply to various populations as they are in that stage. So whether it's a progressive illness like cancer, and we've all seen those different trajectory charts, but again, where we end up in those final days are often the same, where we're bedridden we're very weak. We have impaired swallowing, so we lose the oral route. Poor airway protections, or at risk of pneumonia. Delirium and agitation is common. Pain is often part of the clinical picture, not always, but can be. And we can't clear secretions in the final period often as well. So those are some of the symptoms that we're going to walk through both cases, because no one's going to go through that journey exactly the same, even though there's common elements. And as I was trying to point out, so it could be from a progressive illness like cancer or a neurodegenerative organ failure. It could also be that dwindling of dementia, of frailty, and even some of like, certainly not sudden death, but some more sudden events that would happen, whether it be a stroke or whatnot. You may also end up with that period of the actively dying time. Certainly, I think the point has been made by my colleagues that management of that period is going to go much better if you've had some earlier conversations. And I think we've made the point that even though we're going to focus on symptom management in these final days and weeks, that is not what palliative care is. It's much broader than that, but tonight we're going to focus on that and end-of-life order sets. Okay. So, and again, not to belabor this, because I think Christine made this this point very well in terms of the case studies, but what we're saying that the healthcare team needs to do to manage this time period well is anticipate. So knowing the particular clinical context of that patient's history, what symptoms might worsen or newly arise. We know they're going to have the impaired swallowing issue, so how do we prepare around route changes? Are there pre-existing medical conditions needing attention in final days? So this is where I think we have to start thinking ahead and individualize. So do they have a seizure disorder and they're on Keppra, like our one gentleman there? What are we going to do when he can't swallow his Keppra anymore? What other examples did I give? What if they're on very, very large doses of antipsychotics already? Like somebody potentially with a brain injury or things like that. Are we just going to wait until they lose the ability to swallow and then count on the end-of-life order set to get us through, or are we going to have to make plans around that? What if they're on fairly significant doses of regular benzos now? How are we going to manage that? Even high-dose antidepressants, there's withdrawal effects. So is there a way to plan around that? And one of the things that some of our palliative care colleagues do is transition somebody with, when you see that they're at risk of losing the oral route very soon, give them one dose of Prozac, which is a very long-acting antidepressant that will stay in their system for longer and prevent some of the withdrawal techniques. And I have the reference around that if you want. So I think we're not here, we can't give you all the specifics around things like this, but I would point out in preparation for this, I was talking to one of my Jerry psych colleagues around some of these scenarios. And he mentioned to me that they are going to be available on the race line very soon. So he said those would be the perfect kind of questions to call them up and say, I have a patient on X. I think things are changing for them. I think they're going to be dying in the next little while. How will I manage that period of time? And they, you know, so anticipate, that was what I was trying to get across. Communicate, I think we've talked about that a lot. And then prepare the actual plan. And I think, again, this is where we're saying sometimes we have to go above and beyond the end-of-life order set. How do we do that? So this may look familiar. Oh, thank you, Christine. This is some examples of how we can adjust that care plan. Yes, no, that's okay. And yeah, again, thanks to Christine, that this can, if we plan ahead, this, and sometimes it goes really well, but there can be complications and we just have to be prepared. So getting into some of the, so anticipate and have a plan. Okay, so some of you will be familiar, many of you I think, with the Island Health and end-of-life order set. And we're gonna use this as a starting point as we go through the symptoms. But I think, as was pointed out already with the Liverpool pathway, there are challenges to these kind of standardized sets if we don't use it as a safety net, as sort of a starting point. but how do we make sure that it's individualized to the patient? I think one of the challenges is given that we talked about the challenges of knowing when somebody is dying, and especially when you're dealing with the non-cancer diagnoses, dementia and frailty, how people can fluctuate. And so when is the right time? And then it started, but then they perk up and they start swallowing again, and so the challenges around that. And I don't think I have the answer to that, but I certainly recognize that that's one of the clinical challenges that you guys deal with. Okay, so on to pain management. We are going to catch up, if you're following along in the agenda, we are going to catch up and cover all those topics. So. Okay, so John, who we met there, at this point, he's still able to swallow his long-acting hydromorphone, but he is beginning to moan, and staff are worried that he's getting increased pain. So the nurse did an assessment and reported that the pain is, he's telling us it's in the epigastrium, it's a dull ache to the mid-back. He's telling us it's terrible when asked how bad it is. And now the breakthrough that he's getting is only providing relief for about 2.5 hours, and then he's needing more. And I'll talk about what the U and the V are. So, okay, and then Brenda, because we're trying to look at both cases and look at some of the differences between them. She's no longer swallowing her medication, so she's not getting her Tylenol. The RN reported that her ABI pain scale is 13, and her pain AD scale is 8 out of 10. And then her vitals are there, and exam. So just a reminder that whenever we're sort of the general approach for if you have somebody in pain and you're trying to decide what to do, of course you have to go back to first principles, which would be to do a pain assessment, and normally that would consist of the component of the history, the examination and investigations. Given that we're really talking about end of lifetime, that the role of investigations is pretty much nil. But again, I was just trying to go back to first principles. If you were doing an assessment with somebody who was able to give you a history, you could certainly use the OPQRSTUV mnemonic to help you remember what things are important to pull out, because these are all going to give you clues about how you might better treat it. And just coming back to that understanding and values, what are the goals of care here? Because that's going to shape a lot of the plan. Just a note about a pain assessment in the cognitively impaired, which is obviously a big part of your population. You know, a lot of times people will not be able to give you a history of, you know, what made it better and worse and how long they've had it. But people maintain the ability much longer to just say whether they're in pain at that time. And so sometimes you have to structure how you talk to people. Simple yes or no questions help. Not everyone responds to pain, so sometimes you have to try different words. Does it ache? Does it hurt? You might get responses to different language. You obviously need to get input from family and the team, and observations are critical. And so the things, behavioral indicators that you'd be looking at, vocalizations, breathing patterns, facial patterns, and consolability. I really like that one. Like, how easy is it to distract somebody to make them feel better? And those are the key things that you'll see. So that's why we just put the pain AD up again, just to show you that that's what you'd be scoring if you used this. And both the ABI pain scale and the pain AD scale are supported by, like, are part of what Island Health Residential Care System uses, and you can pull those down from the website, from the intranet. Okay. Common signs of pain in late-stage dementia. Probably not surprising to many of you here that there, and Douglas really spoke to this well in that study, that agitation and behavioral things can be a part of pain. And so if you're seeing that and you're wondering, sometimes it's worth a trial of whether it be Tylenol or a low-dose opioid to see if there's an improvement in behavior, as was suggested by that trial. Okay. Certainly, and again, this definitely applies to those final days, weeks, when you have somebody in increasing pain. Look for the reversible causes. So urinary retention, common when you start opioids sometimes in that stage, positioning, fecal impaction. So those are things that you can do something about. So if we move on to management, really we use the WHO principles of, was really designed for cancer pain management. But again, for this common final pathway, I think there's general consensus that we can use this approach of opioids and stuff. So if we look at that, the main principles would be, so by the latter, and by that I mean, of course, the well-known WHO pain ladder. And if we think about our two patients, they're both describing severe pain situations. So we'd be looking at, you don't have to start step one, right? You move to where you need to be. So it's just a good reminder that we would be looking likely at using a strong opioid. I think it's a good reminder that the plus or minus adjuvant is there. Again, in this time period, there's not a lot of adjuvants you'd be looking at because you're, but something like injectable Dex is something that you might consider in some of these situations, if appropriate clinically. A lot of the other ones, again, in those final week stage, you're not going to be looking at titrating gabapentin or something like that. But and also when you're considering other palliative modalities, again, doesn't usually apply given the goals of care and in those final weeks. But just a good reminder to step back in some situations they might be. Address psychosocial needs. I think that's a good reminder too, because even in the final days, weeks, that may be an element of their distress. Yes?
Can you give me an example of when's a good time to use injectable Dex in a clinical situation? Oh yeah, that's the perfect time.
Well, it's going to be in one of the case studies, but certainly if you thought there was an element of inflammation, so liver capsular pain. So if you think about the mechanism of the pain, and this is why you're doing that full assessment. So if they have liver mets or something like that, if they have brain mets, those would be, so it'd be, I'm thinking probably more malignant pain, and we're going to use it for John. Okay? Thank you. Okay, so going back to the principles, by the clock. So by this we mean if the person now has constant pain, whether either it's because it's malignant, it's cancer, and that's not going to go away, or we're in those final days and weeks of somebody with dementia, but who's using breakthroughs on a regular basis, it really is best to move to scheduled medication. Do you know what PRN stands for? What does it stand for? I didn't catch that. As needed, yeah, that's the true meaning, but we like to say that it means patient receives nothing, because sometimes that's what happens, right? So if they're only on PRN meds, you're kind of reliant on that next shift to do the same assessment. So if you're using a lot and there's regular pain, there should be a conversation with the MRP and say, I think this is the time to put them on regular medications. So by the clock. So, but there still needs to be a PRN available, and it needs to be available in an interval that makes sense. So Q3 doesn't make sense. The time to maximum onset would be like an hour, in fact shorter, for subcutaneous medication. So if they haven't got relief within that hour, that's not sufficient. So that's why we order it like that. And you'd be looking at about 10% of the total daily dose as being an appropriate PRN dose. By mouth, again, this doesn't apply in these final days, weeks. You'd often be looking at subcutaneous medication. So, but generally speaking, the principles, if you can use oral, use it. And then that it needs to be individualized, which I think we've been making the point in lots of ways, and attention to detail, and going back and reassessing. Okay. This really just kind of walks you through how you would approach it. So if you have a resident who is in pain, again, we said assess for the potential causes. Are they already on opioids? And if the answer is yes, but they're just on PRN, is it time to start a regular dose? If they're on a long-acting, but pain has really escalated and now you have unstable pain situation, going back to short-acting is a really good option to get control of pain. And in a longer-term situation, we'd be saying once stable, go back to a long-acting. But in this situation where we're expecting somebody to continue to deteriorate and change quickly, sticking with a Q4 dosing probably makes very good sense. And if you still have pain issues, you're looking at how many breakthroughs they're using, adding that in, increasing the total daily dose if they're still in a lot of pain. But the most important thing is reviewing after 24 hours. How many breakthroughs are they using? Going back, if you're escalating quickly and things don't seem to be getting better, you do have to keep in the back of your mind about opioid-induced neurotoxicity, but I think that's beyond the scope of this talk tonight, but just to put that out there. And then similarly, if they're not on opioids, then you would look at starting them on the low dose. Often we use hydromorphone just because we're looking at the frail elderly with a bit of renal failure, but you could potentially use morphine or hydromorphone. And then again, this assessment, how many breakthroughs are they using? Do we need to adjust? Are they over-sedated? Do we need to back off a little bit? Because they're no longer using any breakthroughs. They're really content, but they're maybe a bit over-sedated. So it's that constant evaluation. I think in the interest of time, I think just to point out, of course, there are side effects. We should be aware of them. In general, people do develop tolerance to the effects. I guess I would just point out respiratory depression is always a concern when you're first starting them and people are near end of life and you're worried about too much and causing them to stop breathing. I would just point out that apneic spells, which we would actually expect as people are changing, that pausing and then breathing and pausing, that's different than the slowing down of breathing from opioids, which tends to be a much more slow, regular. So sometimes people get overly cautious around that because they're seeing some apneic spells or something. We wouldn't want that to stop good pain management. Okay, so how does the end-of-life order set stack up with this? So this is the section from the order set. So it says, if they're on a fentanyl patch, keep that going. That makes sense, because that's one long-acting that they'll continue to be able to get even when they lose their oral route, and give. So then there's a spot for you to calculate an appropriate breakthrough dose every hour. Okay, that one makes sense. If they're already on an oral opioid, calculate the equivalent oral Q4 dose and give half of that sub-QQ. So I guess I would say about that one, it's correct. If you're a physician filling out the order set, you may want to do those calculations and make sure everybody has the dosing. It's all worked out, potentially. That might be an overwhelming order if left and somebody's trying to do it on a Saturday night without as much clinical support or something. So, and then if not taking an oral opioid, then there's a PRN dose there for you, and a fairly good, appropriate starting dose for frail elderly. And then if more than 3 doses required in 24 hours, at that point you should be contacting the MRP around a regular schedule. So I think fairly good advice. So if we go back to John and Brenda, for John, we were going to take that, I'm going to say that 9 hydromorph contin twice a day, plus he was using a number of breakthroughs. We're going to add that all up, convert that to a subcutaneous dose, which would be half the dose, and give it to him every 4 hours, and make sure we have an appropriate breakthrough available on every hour basis. And as I said, I think with John, because when I was thinking about the mechanism of why he's having this pain, and we know that he has pancreatic tumor there, it could have invaded into the liver capsular pain. Certainly a strong anti-inflammatory could be a very good adjuvant, and even though he's losing his oral route, I could still add that in there. Okay. For Brenda, she was opioid naive. She was started on the order set. She got 3 doses of the hydromorph contin subcut on the first day of the order set. So at that point, the physician was contacted and a regular order was instituted, and she was comfortable on that. Okay. So I just thought this was a good quote because the reality is that there probably is still a fair bit of under-treatment of pain at end of life. There was a 2002, which I guess is a bit old now, but study of patients in residential care in the United States who were registered with hospice. So the system works a little bit differently. So they still identify people in their last 6 months of life and they can get extra hospice supports. So of that population, they looked at the minimum data set, and 50% of them were in moderate to severe pain. So it's still prevalent. So given the risk of undertreatment, Clinicians should assess pain frequently and maintain a low threshold for the conclusion that pain exists. Noting the physical condition of the patient, the clinician should ask, would I be in pain? If the answer is yes, it is best to assume that pain exists and that intervention is appropriate. And this was part of the up-to-date article of pain assessment and management in the last weeks of life, and I think that's good advice. So just a few more slides here. Ian asked us to say this is beyond the basics of this talk, so we're trying to put a lot in. I think if we were looking at a pain crisis, which could happen, but is much less likely, but certainly things like a ruptured viscus, pathological fracture, internal hemorrhage, how would we manage that? Well, that's usually the concept of opioid stacking, so you could use 2 times the regular PRN that they had ordered, for example, and give that every 20 to 30 minutes until there was relief. And you could be looking at adding adjuvants for the accompanying anxiety and agitation that would likely come with a pain crisis. So that might be lorazepam or midazolam. Sometimes we'll add Nazanan as a sedating medication, but may also have an adjuvant quality for pain management. So, and then the other sort of beyond the basic one I wanted to mention was methadone. A lot of you have heard of it. It's and because it's being used more for chronic pain, it's really an excellent choice for our renal failure patients. And it is a medication that is long-acting but available in a liquid form. So that's a nice option. And for patients who have swallowing difficulties, and there's maybe a benefit in extra benefit above other opioids for neuropathic pain. So I just wanted to point out there is an online module for learning more about methadone for pain if people are interested. It's a really good online course that's, I think, accredited for 2 hours of CME credit as well. And it's one of those things that will help you move forward with the college for getting a license for methadone. I would just say we're seeing probably more people in long-term care on methadone. And so again, when we're anticipating what do we do when they fully lose the ability to, if they're on tablets, what is the plan when they lose their ability to swallow? So that you can get fairly high strength formulations that could be used sublingually. But again, just thinking ahead, how do we manage that? Okay, off to Christine.
One of the challenges with today is what we're trying to do is pack the whole week-long medical intensive care of the dying course into 2.5 hours. So what I wanted to just speak about end-of-life order sets for a moment and ask when you think as a group is the time to begin the order set, to initiate the order set. Let me just talk about that for a minute.
When people stop eating and stop taking their meds, their oral meds.
So when they're no longer swallowing.
Right.
And so how does that operationalize? Like what happens? Do you call the physician and ask him to, or are they done ahead of time? How does that actually play out?
We call the physician.
Pardon me?
We call the
You call the physician at the point when they stop eating and drinking. So at a PPS of 20%, then you call them. And that's what the end-of-life order set indicates, that it's for 20% and below.
That if it's instituted at 20%, it says, as you call sooner than that, you anticipate they are
Right.
going down.
If you see the decline, you can have it.
Have it there in preparation with an anticipated EPS of 20.
Anybody else want to comment on how they use the order sets? Or how they've seen them used? And I wonder if I could just ask Tom if you can comment about the use of the order sets and how you would imagine. One of
facetiously said, you know, I'm not a fan. But of course, anything that's going to improve care of the patient as they're reaching the final part of their life. It's such a tender, important time of someone's life and also of their family's life. And I think that those end-of-life order sets have been shown to improve. But what I worry about is the individualization and what happens when the patient has this instituted, and maybe and then they get better. And so Tom said that he would speak to that for a little bit.
So I mean, it gives us the dolphin syndrome where they go down, but they come back up again unexpectedly. But we see that commonly enough to say this is actually a very common pattern. And so when we developed the clinical order set, we didn't actually build that into it. So there's been sort of an understanding that the intention is, if that happens, the order set ceases and a reassessment should be done. You should not return to where you were before and reinstitute all of the medications. It is an appropriate time to reconsider whether any of those medications are still appropriate. One of the reasons we see dolphins is because you did the first thing on the order set, which is discontinue all oral medications. And guess what? Some of those oral medications were actually the cause of the decline, and they got better because you stopped them. So it would be a very good idea to reassess where you're going with that, and maybe reinstitute far fewer oral medications. But you do discontinue that order set because it's not appropriate to continue. In fact, they're above the 20%, so it's invalid. But they should be passed order and reinstituted should the time come in the future.
Thank you very much, Tom. That's one of the issues I have with the end-of-life order sets. And the other thing, the way I see the order sets being helpful is that when the patient begins to decline and there's an urgency around the need for that patient to have symptom management, there's an ability to provide them with a stopgap or a bridge until such a time that they can be appropriately assessed. These patients have so many, they're so complex physiologically, their physiology, they change so quickly. They have strong psychosocial and communication needs as well as I mentioned before, spiritual needs. And so rather than the pulling away, oh, the end-of-life order set is there to manage the symptoms, there should be a drawing in to make sure that that order set is appropriate, not just for this moment to bridge them over, but the next day as they change, and the next day, and the next day as they change. So what I don't like about the order sets is I worry that because that's there, then there's not this fulsome attention given to the patient for communication, for reassessment of symptoms, for psychosocial, for information, for supporting the staff. So that's where I have a tension with the end-of-life order sets. So now I'm going to talk about breathlessness. So John, the RN calls the physician. He's had acute onset of breathlessness for about 12 hours. His respiratory rate is greater than 30 per minute. He's on the edge of tachycardia. He seems restless. His nares are flaring, and there's occasional grunting. He looks frightened. He has a furrowed brow. This is something we talk a lot about when we communicate with each other on the hospice ward, is he has a furrowed brow. He's moaning. What does that mean? Sometimes it means pain and discomfort. Sometimes it means fear. Sometimes it means dreaming. But in this case, in the context of what's been happening, it probably means discomfort and may well mean breathlessness. His oxygen saturations are 86, which is different than they were last week, and he keeps pulling off the nebulizer that somebody's trying to give him. And what I wanted to show you was this respiratory distress observation scale. So typically, our observations are not a good measure for how the patient is feeling. We can ask a patient whose accessory muscles are moving and nares are flaring and they're tripoding, and are you feeling short of breath? And they say, no, I'm actually pretty good. You know, are you sure? Yeah, pretty good. But then on the other hand, you can ask someone, you're going through, as I do, with every patient that I see, not only will I ask them for the pain that I've been consulted for, or the nausea and vomiting that I've been consulted for, but I'll ask them about breathlessness. They look perfectly comfortable. Can you rate your shortness of breath on a scale of 0 to 10, where 0 is no breathlessness and 10 is the most severe breathlessness you can imagine? About an 8. And I think, well, maybe they got the scale mixed around. So then I show them the visual analog scale. And they, nope, very distressing. So it's one of these symptoms that we should always ask about. And Douglas, you showed that slide. It showed that pain and shortness of breath were actually fairly equivalent in patients who are dying from cardiovascular disease and from respiratory disease as well. And I would say it's one of those final common pathways of dying is breathlessness. So this scale is somewhat controversial, developed in 2009 by a PhD nurse, but it's one which I will pay a bit of attention to because I don't have any other ways to understand if this patient is breathless. What is the heart rate? What is the respiratory rate? What's going on with their abdominal movement, their nasal flaring, and the look of fear is probably the most telling of all, is that facial expression. And if you go online, Google this, they actually have a chart that shows examples of the faces and can tell you how to score it on this respiratory distress scale. This may be cumbersome in some settings, but it's not just for research. It's to communicate with each other and it's to assess the patients. So this is what we've got. And what I want to show you is how my idea of managing breathlessness is different than what you see on that end-of-life order set. And I also want to ask the nurses in the room, how many of you have gone through and done this calculation with the end-of-life order set? Done it? See 1, 2, 3. How many feel comfortable doing it? It's within your scope of practice, and yet it feels uncomfortable because you don't do it regularly. And so I would say that for physicians who are filling out that end-of-life order set, I think it's part of our responsibility to the people that we look after, to the staff that we work with, that we kind of, when we're thinking ahead that they might need the order set, Leah said it very politely, maybe you should kind of write those orders and do the calculations. I'm saying it very firmly that I think that's part of our role when we're doing the end-of-life order set. We don't rely on our staff. When I do those calculations, I check with a nurse or even with another physician as part of my team. And I think that we should be very careful with the orders that we leave for our patients as well. So, general symptom management approach. This is not just for breathlessness. Reverse the reversible, manage with pharmacy, manage with non-pharmacy, educate and support. So that's your sort of four-pronged approach for anything. Pain, shortness of breath, nausea and vomiting, respiratory secretions, whatever. So for breathlessness, the reversible piece as they're heading into a PPS of 20%, it's a little bit less. You're not going to drain a pleural effusion or give them a blood transfusion or treat a pneumonia necessarily at this point. But the baseline breathlessness is really important to separate from the incident breathlessness and the breathlessness that comes with anxiety, even at a PPS of 20%. For that baseline breathlessness or that pain with minimal activity, opioids around the clock by the WHO ladder, just as you would provide for pain. When patients are breathless, what do? They stop moving so they're not so breathless to gain some control. So if you had a patient who had pain and rolled around on the bed and they developed pain, you'd probably increase their opioids. Same with breathlessness. They're lying in bed and they're fine when they're still, but then they move a little bit, you should be thinking about increasing their baseline opioids. Breakthrough every 1 hour is needed, and call the family physician or the MRP if they're needing more than 3 breakthroughs. That's that moving in. How many breakthroughs did they take in the last 24 hours? Maybe not so many. We can leave the dose at the same or titrate up if needed. For incident breathlessness, this is something that's being very well studied in the literature right now, more for people who are upstream, but using ultra-short-acting opioids such as fentanyl or sufentanil. This medication has a fast onset, about 5-10 minutes, in the system for about 30 minutes. So just for that period of time that it's needed. And I've been experimenting a little bit with intranasal fentanyl and sufentanil. I have used intranasal midazolam to offset seizures in a child at home. I have not yet been using that regularly, certainly not in residential care, occasionally intranasal in the home. But I'm wondering if this might be something that you might consider in your practice if you're needing some quick onset, quick offset treatment for either breathlessness or pain. Just a little wondering, kind of a neat trick that you might try. Douglas, are we using that on the unit at all? We're not using it on the unit, but some places are. And then, so back when I started doing palliative care, when someone was breathless, the first thing you would give them is what? An opioid or a benzo? Like 10 years ago, 15 years ago. I was taught to use a benzo first to deal with the anxiety because everybody who has breathlessness has anxiety and that can help. Well, actually, that's not true. Not everybody with breathlessness has anxiety. Many do. But what we want to do is treat the underlying symptom, which is breathlessness, and that is best treated with the opioid as first line and the benzo as second line. This way we're avoiding polypharmacy and sedation, and I'm running out of time. Opioids first, Ativan or midazolam, if and only if they have anxiety. Methotrimiprazine is discussed as an adjuvant, and sometimes people will just order it. PRN, breathlessness. We don't have a lot of evidence for its use. Its benefit, I believe, is mostly because of its sedative properties and its anxiolytic properties. Non-pharmacological treatments, as with most of what we do, are completely undervalued. But these are treatments that can be provided by the care staff, and it gives them a lot of power. They should be acknowledged and they should be part of the care plan. Loose clothing, loose sheets, a fan. There's some beautiful crossover studies that show that a fan does indeed relieve breathlessness, especially when held about 6 inches in front of the face, blown on the nares. Anybody interested, have a look at a website called Breathlessness Intervention Services. There's some beautiful patient information handouts on how to use a fan. When I'm in the home with somebody, I go over it with them in the home, show them how to use it, send them out to Canadian Tire for a handheld fan. Oxygen, unlike non-pharmacological treatments, is overused. Breathlessness is such a complex symptom. It is not driven only by hypoxia, and usually there's many etiologies of shortness of breath, of which hypoxia is only one. Opioids have been shown to actually be better even for patients who are hypoxic, but sometimes we will still use oxygen. It's the airflow often that's helpful, and sometimes a fan can be just as useful as the airflow. Also, excellent mouth care, undervalued. Mixture of a liter of water with a half teaspoon of salt and a teaspoon of baking soda makes a great mouth rinse. These patients mouth breathe, gets very uncomfortable, and it can aggravate their sense of breathlessness. I like moisture. In my little doctor's bag that I carry around with me to the patient's home when I open up, like my Mary Poppins bag, in it, I carry around with me a little bottle of moisture. Patients PPS of 20%, spray inside their mouth. I'm a hero because it's an under-recognized source of suffering, that sense of dry mouth. Prepare for the acute crisis. Your patients with COPD and congestive heart failure may well get into a crisis. John got into a crisis here for perhaps a myriad of reasons. Maybe he had a pulmonary embolism. Maybe he had a bleed. We don't know. We're not going to investigate him, but we need to respond. Orders can be prepared for in advance. You can use breathlessness crisis orders just as you would for pain crisis orders. Usually, if you're on a regular dose of hydromorphone, when we're setting in a crisis order, you can use 1 time the dose of the regular sub-Q, given every 30 minutes. But really, our protocols for palliative care emergency requires that we do a double dose. It's quite safe for someone who's been on regular opioids. It's not going to cause them to stop breathing. Sometimes we need to add sedation in as well. And educate the family. Provide them with information on why their patient is breathless, what you're doing, and reassure them that this can be managed in the facility. The families at the bedside are so focused on any little change that their loved one is experiencing. And breathlessness has been shown through qualitative studies to be as distressing as severe pain, severe agitation. And that might be what sparks them to say, you guys can't manage this here. That patient, my mom needs to go to emergency. But if they know that you've thought about it, that the orders are in place, these are the tasks you're going to do to make sure your mom is comfortable, and they can see that you respond. And the most beneficial symptom for that family when things are going sideways is to have someone who's capable at the bedside. And if they've seen their physician recently, that can be very helpful as well. Okay, beyond the order set, sub-Q furosemide, off-label of course, but can be used. I've used a subcutaneous infusion of furosemide to deal with someone with horrible edema with excellent, excellent symptomatic benefit. And surprise, surprise, I thought I was going to push her into renal failure. I did not. COPD, they're on prednisone. You can switch that over to subcutaneous dexamethasone. Generally, we avoid nebulizers, but of course that's individualized. Time and time again, I hear that the patients have been put on antibiotics for comfort, so they don't have a cough, so they don't have breathlessness. That is not necessary. We can manage those symptoms through good palliation using opioids, which will help with their breathlessness, anxiolytics to deal with their anxiety of breathlessness, good mouth care, and the cough will also respond to opioids. Not necessary to have antibiotics for comfort. I can do nausea and vomiting super quick. Poor Brenda, she sometimes got coffee ground emesis, sometimes flecked with bright red blood. End of life order set, 0.5 sub-Q instituted, but requiring 3 breakthroughs of this daily. Not going to spend a lot of time on nausea and vomiting, but Haldol is not the only drug out there for nausea. Please avoid Gravol. It's like 5th line for me using Gravol because I know you guys have heard this time and time again about the aggravation of delirium and making them agitated. If they have delayed gastric emptying or dysmotility, metoclopramide is the drug of choice. Someone who's been on a newly instituted on an opioid who's vomiting, we would tend to use metoclopramide. But I think what happens sometimes that we miss is those patients at some point get agitated. And what we see is akathisia in a patient who's not able to get up and pace and walk around. And so what do? We treat them with a neuroleptic to try and settle them down, and their agitation gets worse. And then we use a benzo. So just be mindful that this side effect of akathisia can look different in a patient who's imminently dying. And then, of course, be watching for Parkinsonian side effects. I also think we assume stiffness is part of the dying process. Well, actually, it's a side effect of the medications we're giving, so watch that. However, if a patient was very symptomatic, you use metoclopramide to settle their nausea and vomiting, and they're imminently dying, you may choose to use an Ativan to settle that stiffness to allow them to gently move into death over the next few days. Refractory. There's a few drugs that are great for refractory nausea and vomiting, and none of them are ondansetron. Ondansetron is an expensive medication with very few indications for nausea and vomiting. In the palliative care literature, we have support for using methotrimiprazine when there's refractory nausea and vomiting, as well as an olanzapine. And when I have used it in the home situation, when I don't have access to injectables, I've used the olanzapine wafer. It's totally off-label. Marital palliative care benefits cover it for nausea and vomiting now? I wish I knew. Olanzapine, no. Okay, it's off-label. You call the pharmacare people, take a deep breath. You know, this patient's dying at home. They're terribly symptomatic. I've tried this, I've tried that, and almost always you get it approved. Avoid Gravol and an off-label Pearl. Ranitidine can be used subcutaneously. if they have a lot of gastritis. So there's my nausea and vomiting in 5 minutes. Agitation. So back to our patient Brenda. So we had started her on the regular Dilaudid, and she settled initially, but then she became more and more restless and agitated. She was pulling at her catheter, she was picking at the bed sheets, and this was new behavior for her. She was calling out and resistant to care. So how will we assess and manage this situation? So I guess first thing to acknowledge, it is hard to sometimes separate out pain from delirium, agitation, restlessness, and sometimes you just have to go with the clues that you have, but sometimes it is trial and error of what you're trying. But we certainly know that, for some people, these final days can go more smoothly, and for others, there is more restlessness, agitation, hallucinations, delirium, certainly also very possible. So how do we manage that? Of course, we all know common causes of delirium at end-of-life care, but again, because we're not looking at reversible things, it's oftentimes not relevant to be thinking about this. And in a lot of times, if you're explaining it to family, it's really the full burden of their disease at that point. But maybe more to the point, we should be still thinking about different causes of the restlessness piece. Certainly the physical, the pain, the constipation, potentially the bladder retention we talked about before. Is it drugs contributing, as Christine mentioned? So the extrapyramidal effects or akathisia from something that we're giving them, opioid-induced neurotoxicity. And is it possible that there is a psychosocial component with anxiety or existential anguish? I sort of skipped ahead because I did have one where we talked about management, where we do still look at non-pharmacological approaches. So whether that be a calm environment, avoiding restraints, and again, mentioning communication with family, because this can be a very difficult experience for people, maybe less so for a loved one that has dementia and that has already been an issue, but for a patient like John, where his wife was still communicating with him and then things were to drastically change. So understanding and having a bit of information about where that's coming from and why that doesn't represent him if he's acting in a way that she's not used to. But moving on to the drug management, especially in the interest of time, the gold standard is still an antipsychotic for a hyperactive or agitated patient. And so that does line up with the end-of-life order set, starting with Haldol, and looking at using ones with increased sedation if that agitation is worse or not responding to the first level ones. This guideline would say avoid benzodiazepine, but I think that is different when we're looking at a terminal delirium, and that's why I think it's quite appropriate that Ativan is started fairly early on too, as part of the end-of-life order set, and we'll get to there in a second. But I did just want to put the slide in to point out that there have been the recently released BC guidelines around palliative care. So there are a number of guidelines for patients with incurable cancer or advanced disease now available on the internet through the bcguidelines.ca website, and delirium is one of them, and this is just the snapshot of the pharmacological treatment of delirium. And you'll see as well, they do talk about sedating with a benzodiazepine if there is extreme agitation, patient safety, staff safety, and I would also argue in a terminal delirium. Okay, just wanted to put this slide in that some of you may have heard about this study, and there's been a couple of journal clubs with geriatrics and different people looking at this and looking at the role of antipsychotics in delirium. And because even though we use it, there's very little literature, and they're all used off-label. None of them have FDA in the States and approval for use in delirium. And so this really was looking at it, and it showed that actually people seem to have worse symptoms. There was perhaps shortened survival with as opposed to placebo when they used the antipsychotics. But I just wanted to point that out because if you're hearing that,
Again, I don't think we should let that change our management at this point without further information around a patient population where it is more clearly a terminal delirium. This was not. And their delirium scores were more mild to moderate as opposed to the more severe. So if you've been hearing and questioning the role of antipsychotics, I don't think we're ready to switch over the management of end-of-life patients in residential care at this point. So I'd still say we can safely use the order set where it's starting with the Haldol, adding lorazepam, and if still agitated, moving on to a methylprednisolone. So I'm not saying there can't be personalization of this, but I think this is a good starting point. So if we go back to Brenda, for her, they did start the Haldol 1 milligram BID, and they were also using PRNs because she was still a little bit agitated, so they moved on to Ativan 1 milligram TID. She was also using PRNs of that. So when there was a review by the physician after 24 hours and looking at the overall situation, it was decided to step it up to a more sedating antipsychotic, the methylprednisolone. It was ordered regularly, and the Ativan was continued, and she settled and looked quite comfortable. And this is where I think, again, we go back to those skills that Christine is talking about, and how do we assess at the bedside what a settled patient looks like, a calm patient, not the furrowed brow, not the eyes, wide open in fear and deer in headlights kind of look. So how are we assessing that? Do we feel comfortable with that? Okay. Oh, I will go back to, there's always going to be people that don't respond to what's on the order set. And if it's not responding, we go back, look at potential causes. Again, are we actually making things worse with what we've added? Are we getting paradoxical responses to the antipsychotics or the benzodiazepine? But we would be looking at trying escalating doses. At some point, we might switch gears and say, maybe we need to look at a different agent if we're not getting good response to this. Can we look at phenobarb? And that would be one we would use as sort of a third line in a more agitated delirium. Any questions? Okay. Christine, I'm wondering whether, just in the interest of time, if I just, and then we come back to, we were going to put secretions last, which does fit very well, but it'd be quicker if we don't have to switch. So I was just going to talk a little bit about more urgent situations or crises. And we thought about different ones where you might be called about situations within residential care, and we tried to integrate them into the earlier parts. So as far as the severe breathlessness and pain, next steps for agitation. We also wanted to touch on seizures and hemorrhage, so I'll do that quickly now, but also acknowledging, and I have to say Christine does this so much better, but that there can be a lot of family distress or staff distress if things aren't going well, or sometimes even when they are, but there's challenges with coping. And those are things that I think the team really appreciates, that the physician can lean in and help in those situations as well. So opportunities, how did you put it? Just to step forward and to make that go better, because as we said, families only get the one chance to do this. You only die once, and our job is to try to make that go as smoothly as possible. I think our bereavement and counseling service would back me up on saying that when things don't go well, that stays with people and lives with people a lot. And there's a lot of complicated grief sometimes when people perceive or think that things haven't gone well. Okay. Just quickly, I would say anyone with a seizure disorder, you would try to maintain their oral anti-seizure drug as long as you're able. But when they're no longer able to swallow, a decision has to be made whether you're just going to discontinue it, which might be appropriate in somebody with a very remote history and it's a bit vague, versus starting a benzodiazepine on a regular basis, or maybe starting phenobarb, because that can be given subcutaneously to prevent seizures. But certainly you would always want to have a benzodiazepine available as an abortive medication, and that is not on the order set, so that's something that you would want to be proactively order. So usually lorazepam is the drug of choice, and I gave some guidelines for treatment of partial seizure and then generalized tonic-clonic seizures. And I took these, if anyone's, this is just another plug for resources out there. Fraser Health has put all of their palliative care guidelines online. They're very similar to what all the health authorities have adopted, and actually there's a process right now going on to update all of these guidelines and have them provincial through the BC Centre for Palliative Care. But at this point, before those are released, the most recent ones are easily Googleable, is that a verb? Through Fraser Health Palliative Care order sets, and you will get the whole gamut of pain management, seizure management, hiccups, everything. And so I gave the reference there, though, if you're having trouble. So that's where these guidelines came from. Okay. And then similarly, you may also have a patient, whether it's because they have a head and neck cancer, or they've had a fairly large hemoptysis from their squamous cell lung cancer before, and you know that they're at risk. People also have GI bleeds. So if you have a patient that is one of your concerns, again, you want to be thinking ahead, planning ahead, what can you provide in the orders? Because an exsanguination at the end of life can be quite traumatic for the staff or the family, whether that be a quick bleed where things are over very quickly, or a more prolonged, ongoing GI bleed, but that is considered to be a terminal bleed. How do you handle that? So having some discussions as a team about that possibility and what we would do. So, one of the fairly easily done things at hospice is there's a kit that has dark towels that's put in the room. So those kind of things can be, because the dark towels would not, if you use them to soak up the blood, wouldn't have that same visual effect on families and that sort of thing. So to have that kind of thing available, to have crisis orders available. But again, you have to use judgment, because if you have a massive bleed and you run off to go get the midazolam and you leave the person, you have to make a judgment whether you should just be staying and holding their hand and talking to them as they depart this world, or whether this is going to be something that is more of a process over time, that you have time to get some medication. So that's a judgment call, but there can certainly be medications that are available there. And again, we talked about having that double dose of opioids available, plus say a midazolam order. So that would be fairly common crisis type orders to be available. Okay.
Thank you, Leah. And you were talking about you have to make a decision when there's a crisis. And I just wanted to share a story, since we have a little bit of time, about a patient that I went to go see. And it was a very meaningful story for me, and so I apologize if some of you have heard it before. And I was going to see a woman at her home, and sometimes you don't remember things from one patient to another, but I remember walking up her yard, which you could see had been a bit unkempt. There were huge statues. You could kind of tell she was from the Mediterranean. There was a white marble water bath with a little boy peeing out of it, into a cup. And so those are details that I wouldn't usually remember, but I think I remember it because of what happened when I went into the house. So she was there with her daughter, who was in her 50s, about the same age as I. And I was there because it was about the talk, as we say, what's going to be lying ahead and what feels most important. But she was in the bathroom, and something clearly had happened in the bathroom that was just adjacent to her bedroom. And when I arrived, she was completely blue in the face, also her fingers, and she was extremely breathless. And so we assisted her to her bed, had her reclining with head somewhat elevated. And I thought, I don't have any drugs. If only I need to start carrying, all this stuff's going in through my head. I need to start carrying morphine on my kid. I need to have subcutaneous midazolam so I can manage situations like this. I can't believe I'm such a terrible doctor that I don't have this stuff. I have no power. So what I did instead, I had a medical student with me, was I laid down on the bed not completely. My feet were still on the floor, but I laid down on the bed and touched her forehead and told her that I wasn't going anywhere. And I looked over at the distraught daughter, and I invited her to come to the other side. So she laid down on the other side of the bed. And so that, because she had been fluttering around, uncertain what to do. And that lady died in probably a minute and a half. And it was one of the most powerful experiences of my professional career. Maybe even as a palliative care physician, maybe the third time I was actually in the same room with a patient as they were dying. But I thought later, reflected later, that if I had had drugs in my kit, I would have had my back turned to her, drawing up the medications. The daughter might still have been fluttering around instead of lying beside the bed. So the role that I played there was being a model for that daughter to help her through that really, really difficult time at the moment of her mother's death. And I like to think that I was able to offer some comfort. That by the time those medications would have kicked in anyway, she would have died. They wouldn't have had a chance to have worked. So that story made, what you said made me remember that patient who will be with me, I'm sure, until the day that I die. So now, I guess that's a good story to tell before the final hours. And again, when I first started doing palliative care, it makes me sound like an old fogey, which I sort of am, getting there. And I started doing this work about 15 years ago, and at that time, it was all PPS of 20 and 10% and below. And of course, palliative care has moved so much farther upstream now, and I'm glad for that, and it's exciting work that we're doing. But the core of the work that we do is this bedside presence at the very final part of life. And Michael Downing showed some of these slides at the very first palliative care conference that I went to. And I like to see it because it kind of made sense academically to me. But when the family sit at the bedside, they, like I said before, they're watching everything. They're paying a lot of attention to how the patient is breathing. And they will be very distressed by it. I have had experiences where I've been told that despite the medications that we provided, the patient appeared to be breathless. And yet that can be a misinterpretation of some of the normal breathing patterns at the end of life, of which I'm going to go through. So the first one is one which I learned in medical school, but it was really the only pattern breathing that I was really aware of. There's lots of things to push on here. Okay, so you've got this period of hyperpnea, or rapid breathing, that starts low, goes to a crescendo, down again, stops, and then the patient will breathe again. But if you watch long enough, you can see that pattern. And what's happening is that the breathing, this is where the brain is beginning to shut down. And this is why we see this most often, this Cheyenne-Stokes respiration in patients who've got congestive heart failure. They've got a bit of hypoxia. When they sleep, they dip down a little bit lower in their oxygen, and they begin to exhibit this Cheyenne-Stokes respiration. So your breathing is controlled at that point at the diencephalon level. These don't always happen, and they don't always happen in a certain order. But the first patient who's I was in the room when this fellow died, I thought he was breathless. And he had this constant tachypnea and hyperpnea, deep, deep breathing. And it looks like the patient might be short of breath, but in fact, it's a normal breathing pattern for the end of life. Now we're down at the midbrain, or pons, breathing deeper and deeper. And finally, you've got this cluster breathing. And this is where you'll see the apnea, and it can go on for 10 seconds, and then later it'll go on for 45 seconds, sometimes as long as a minute, and you think, okay, this is it, and then they take a deep breath, and it's not quite it yet. And so that's the cluster breathing, further below, further deeper. And then there is and I used to have the slide for agonal breathing, where you'd have a deep breath and then nothing, and then a shallow breath, and then a deep breath and then a medium breath. And there's really no pattern except for the fact that there's the apneic breathing. And again, as Leah mentioned, this can be misinterpreted as slowing of the breathing because of the opioid. And the staff who's giving the opioid is worried that they're going to be further slowing the breath even more unless they know that this is a normal breathing pattern at the end of life. Respiratory congestion. I did a little bit of research on this when I was a resident, and it was extremely frustrating research, actually. But so I got to know it a little bit. But really, we don't know what the natural history is of death rattle. We don't call it death rattle so much because that sounds kind of harsh. We tend to call it respiratory congestion, but many patients and families will know it as death rattle. And it's just that congestion that occurs in the back of the throat. In a non-residential care setting, we don't really know how often this occurs in the residential care setting because there's been absolutely no research really done in the frail population. I thought, well, maybe it will occur less often because they're more frail, they maybe have a longer trajectory, and so they get dehydrated, and maybe they're not going to be producing so much respiratory congestion. And yet what they found was that risk factors was prolonged dying. So I don't think we can really know that. But increased risk if they've got pneumonia, which many of residential care patients will die of pneumonia, or metastatic disease, brain injury, and dysphagia. So they have risk factors. Not really known, however. There's two types described in the literature. Type 1 is really just salivary secretions that, because the reflex of swallowing disappears, gets in the back of the throat. So it's just the tube breathing in, breathing out. And then the type 2, which is more bronchial secretion. And there's a suggestion, just a suggestion from the literature, that what we do with our anticholinergics is really just treating type 1 and not type 2. But we always tick it off on the order sheet because that's what we're supposed to do. But there's no excellent research to guide us at all. There's some studies that show that glycopyrrolate is equal to scopolamine is equal to atropine. There was a randomized controlled trial that came out just 2 years ago. I think I reference it in the next slide, that showed that sublingual atropine is actually no better than placebo. And when I read that, I thought, oh, this is great. We have a randomized controlled trial in a palliative care patient that can guide what we're going to do. But when you look at the study, they use sublingual atropine, which when you actually look at the pharmacokinetics, it doesn't get absorbed across the buccal mucosa. Well, maybe they're swallowing it. Doesn't get absorbed across the GI tract either. So it probably wasn't getting systemic anyway. So if they'd done that trial where they'd done sub-Q atropine, then maybe that would have given us nice information. However, there are some places that you will go. BC, we tend to treat respiratory congestion. But some places, they don't. So why do we treat? Are we treating because for the comfort of the patient? Are we treating because we feel like we want to do something? We need to do something? Are we treating for the family experience? And I can imagine it would be hard to hear your loved one rattly breathing, and it can be upsetting, and we think instinctively that it is upsetting. And what was interesting to me, the most fun, I guess fun's not quite the right word, the most engaging part of the research I did, which showed a lot to me about where I wanted to go with my future in research, which was nowhere, was sitting talking to patients, sitting talking to the families about what it was like to be at the bedside. And I didn't publish any of this because it was only part of the consent. But what they told me was that, the nurse told me that there was going to be this rattly breathing. And then that rattly breathing happened, and then I knew we were in the last couple of days of life. And so it was a bit of a relief because I knew it was coming, and I knew that meant that we were almost there. So for that family, it wasn't upsetting at all. And yet, I have a dear friend whose father died on the unit about 2004. And he had very rattly breathing that you could actually hear out in the hallway. And she wanted to say goodbye to her dad. So my friend held up the phone to Dad's ear so she could say what she wanted to say to her dad before he died. And all she heard was the rattly breathing. And she says she still feels traumatized by that. Because I think it's not so much, maybe I don't know if I put it up there. The way I've kind of thought about it is the distress, people feel distress and grief because their loved one is dying. And all of that can kind of be put on that sound of the respiratory congestion, and that just mixes it all up. So I don't know if just talking to families, counseling them, giving them information about what's going on, probably their loved one isn't upset. We can describe to them, I don't see a furrowed brow. Their limbs seem very relaxed. I don't think they're distressed by this. So we can reassure the family in that way. But we can treat. I don't know what the right answer is. But my suggestion is that we prepare the family for the possibility of changes in the breathing patterns, particularly apneic spells and respiratory congestion, explain what is happening, and that we get in our brain that the primary treatment is not anticholinergic. Anticholinergic is one of the tools that we can use. But positioning has been shown to be equivalent in this not so great research that we have. Generally, we say don't use suction, but I had one occasion last week or the week before where we actually arranged to get suction in the home because someone had profuse pulmonary edema, and we wanted to use some suction. And if you use an anticholinergic, you have choices. You've got atropine, you've got scopolamine, and you've got glycopyrrolate. Glycopyrrolate is a quaternary amine, so it doesn't cross the blood-brain barrier, and so it's less likely to cause agitation. Atropine is felt to maybe, although we don't really know, have more effect on those type 2 secretions because it can affect the bronchial secretory work. I lost my brain there for a minute. So it may be more effective for those type 2 secretions. And yet, it can cross the blood-brain barrier. Anticholinergic in its way might make agitation and delirium worse at the end of life. Scopolamine, I haven't had a lot of experience with it, but I know it's extensively used in other situations. I have used the transderm, here's a little pearl for you, the transderm V patches that we use for motion sickness. When someone's dying at home, this may or may not be helpful in a residential care facility, and you don't have someone that can give an injection, you can put a transderm V patch, and that may assist, we don't really know, with some of those secretions. But your dose isn't going to be enough unless you use 2. You don't just, if you're going to use it, don't just use 1, put 2 transderm V patches on, and then you change it every 72 hours. And the last thing I want to say about it, if you are choosing to use anticholinergic medications, and you will receive pressure to do it, because that's our practice. It's not based in research, but that's our practice because we're wanting to do something. Is that those anticholinergics don't work on secretions that are already there. The body will absorb those secretions, but they will prevent secretions further from happening. So if you're going to use it, you start it and you use it regularly. So I probably have caused more confusion than I have caused clarity, than I have created clarity around terminal secretions, except for the fact that you need to be providing counseling to the family and staff about this very common symptom. And I also want to say that not all congestion is terminal respiratory secretions. You know, it's not just salivary secretions or bronchial secretions. This might be someone who's dying of congestive heart failure and actually has pulmonary edema, and the right thing to do in that situation might be to give them some sub-Q furosemide. The right thing there to do might be to give them some sub-Q dexamethasone if they're dying from COPD or metastatic lung disease. So not so clear as we thought. So the pardon? A question? That's a very good question. So that's another issue. So is it leading to agitation? Is it leading to dry mouth? And the way that we react to that is that we're already giving good mouth care, right? So making sure that their mouths are treated every couple of hours, Vaseline on the lips, maybe some spray of artificial saliva. The other thing that can happen is that, I forgot where I was going with that, but sometimes people can get myoclonus as well. You guys have probably seen that. maybe, we classically see that when people are opioid neurotoxic. We use Ativan to treat that towards the end of life, but I wonder if it's neurotoxic from opioids. You can probably get neurotoxic from all of the myriad of complex neurophysiological things that are happening to someone when they're dying. So treating it symptomatically with a Ativan. So questions?
Mine's not about the breathless or the respiratory congestion. Throughout a couple of the topics you brought up, midazolam.
Right.
I'm quite comfortable using it because I've worked at Victoria Hospital with you guys. But when I joined residential care, our geriatric psychiatrist recommended using midazolam, and between myself, the geriatric psychiatrist, and the pharmacist, we could not find any policies or procedures for how to use midazolam in residential care. So the three of us in RCNL, who was game to give it a go, sat down with the pediatric dental protocol for midazolam to figure out how to monitor this patient for short-term use of midazolam. She was getting it to help her with backs because she was so fearful and violent during that. So it would be great.
Would it be helpful to have, is that something that would be helpful to
have?
Very helpful to have a policy and physicians are comfortable with or have ever used before. But also you talked about the continuous midazolam in residential care.
Well, I have never used continuous midazolam in residential care, but residential care are our modern hospices, right? 30% of people die in residential care. In our province, maybe a little bit more in Douglas probably has.
You've done it once in Sunset Lodge.
Oh, done it once at Sunset Lodge, and that probably was with a lot of Victoria Hospice support, right? And the home and community care nursing reacts quite significantly with fear when we use subcutaneous midazolam in the home. We do use it, but it's around not being familiar with it, and it's around the story that we tell around this medication. And it's around the story that we use it for palliative sedation, and that what are we actually doing here? This is, and fear around respiratory depression, and the thought that in this situation we need to have specific monitoring. At the end of life, we do monitor our patients, but we're monitoring them in a different way. We're monitoring them for the target symptom, and we will accept, we don't want to cause side effects, and we will monitor for side effects. But there's maybe a bit more flexibility. And I hope I'm saying that correctly. Leah, would that, from your, as a palliative and end-of-life medical director? Do you think that we could be using midazolam in the residential care facilities? Okay. Oh, here's the barriers. Here we go. Yeah.
And many of the nurses in residential care have never used or maybe learned in nursing school however long ago that was. And I'm one RN for 80, and the LPNs were one for 36. So love the drug, works really well, but there's also that you want to be able to monitor.
Okay, I have one thing to say about CAD pumps in residential care. And right now, when people head towards the end of life, we're giving them intermittent opioids. Every 4 hours, that nurse is going in, and that's good because that patient's getting monitored. It's the same for families at home. They're needing to get up in the middle of the night to be providing these Q4 hourly medications. With syringe drivers or CAD pumps, and we've chosen in our locale to use CAD pumps because of their safety issue. That medication is delivered continuously 24 hours, and you don't have to be going in every 4 hours. So I think it's a lovely fit, but there are a lot of barriers to get them in. Money. I mean, I'm not an administrator, so I don't understand all of the barriers, but I can imagine there would be a number. But, and I'm not talking just for midazolam, I'm talking about for opioids, for other medications. So thank you for bringing that up, that sometimes, although you hear about these wonderful ways to manage symptoms, they're not easily applied in your setting, and I apologize for that.
Pharmacy is a barrier.
Pharmacy.
Well, because none of these drugs will have the ability to be opioid to actually be there, so you've got to order them, get that from the pharmacy somewhere, and it might not happen either. So that's the
Right, so it's kind of like someone being in the home.
Exactly.
Again, you have to be proactive about it because you got to get those medications where they need to be.
Thank you so much. This was excellent. I learned a lot. Give them a big round of applause.